Good afternoon and welcome to the OR Today webinar series. We're excited to have over 460 registered attendees for today's webinar. I want to remind you today's webinar is eligible for one continuing education hour. And to let you know, we've now automated the post-webinar survey and certificate process and hope that you'll find it more convenient. The survey link will be included in the follow-up email, which you will receive about an hour after this webinar has finished. Once you've completed the survey, you'll be able to download your certificate immediately. One lucky attendee will still win an Amazon gift card for completing the survey. Okay, let's kick off today's webinar by giving away an OR Today live surprise pack to the attendee that can tell me the answer to the following trivia question. Today's sponsor, Medline, is headquartered in Illinois. What is the name of the first and oldest hospital built in Chicago? Answer now using the questions feature on your dashboard. While you're answering, just a reminder that our 5th annual OR Today Live Surgical Conference takes place this weekend at the Palms Casino Resort and Spa in Las Vegas. Join us to discover new opportunities, broaden your knowledge, and exchange ideas. Registration is still open, and for more information, visit ortodaylive.com. Okay, and let's see who has won our OR Today surprise pack, and it's congratulations to Ren Scott. Congratulations, Ren. Of course, the answer is Mercy Hospital. OR Today would like to thank our sponsor, Medline Industries. Medline is the largest privately held manufacturer and distributor of medical supplies uniquely positioned to provide products, education, and support across the continuum of care. Medline's ability to bring best practices from one care setting to another, from large health care systems and independent physician practices to home health patients and their families, is what sets them apart. For more information, visit medline.com. Okay, our presenter today is Dr. Rosie Lyles, Director of Clinical Affairs at Medline Industries. Rosie, you may begin whenever you're ready.
Thank you so much. First, I want to say thank you to everyone who was attending, who have signed in to hear my talk today, and also to OR Today to allow me to talk to you about a very important topic and how we can prevent surgical site infections by using topical antiseptics. I only have one disclosure. I am an employee of Medline Industries. So my overall objective today for this webinar would be the following: to explain the clinical and economic impact of surgical site infections, known as SSIs, on patients as well as healthcare facilities, describe factors that increase risk of SSIs, and discuss effective strategies to prevent SSIs, discuss clinical evidence related to the use of effective antiseptic agents to reduce infections, and lastly, also to identify strategies to enhance patient compliance to prevent these surgical site infections. First, I'll just discuss about the clinical and economic impact of surgical site infections. As an introduction, I think it's very important to announce and to say that preventing surgical site infections is a primary goal of all healthcare providers. And the key to do this successfully is understanding the risk factors for surgical site infections, implementing effective infection prevention strategies, also providing proper education to ensure or boost compliance with patients as well. If you look at the overall hospital-acquired infections, in the healthcare setting today, we know that pneumonia as well as surgical site infections are tied as the highest of infections that we see in the acute care settings. But if we go down a second, more deeper to see at the cost, how these infections affect not only the cost of these infections, but also the length of stay for patients overall, we know that for surgical site infections, it ranged between $20,000 to $42,000 in reference to pay for these clinical infections caused by MRSA. Also, the length of stay can increase from 11 days to 23 days, depending upon if they have a MRSA infection or just a staph infection caused by surgical site infections. But also we know that there's a scenario in reference to the estimated for hospitals costs associated with preventable HAIs if the healthcare facility does not have the antiseptics available to prevent these infections. And we know from data that shows that if you do not have these antiseptic agents available to prevent these infections, it can cost you around $14,000 to $41,000 per infection in the U.S. for surgical site infections. Also, we know that there is a direct cost for surgical site infections. It has the prolonged length of stay, you have readmissions, additional visits, additional procedures, lab tests, prolonged antibiotic use, home care, and additional drugs and professional fees. But there's also an indirect cost when you think about the patients and how it affects patients as well. They have lost productivity from work, they can't work. Also, they have a mental decapacity in reference to the known of having an infection from their surgery, but also from the healthcare facility, they have an indirect cost as well. You have the indirect cost for labor, indirect cost for the facility used out of pocket, and also too, patients can give a bad report in reference to the satisfaction of the service they receive from being an inpatient as well. So if we look at the factors that increase the risk of surgical site infections, we know that from data that surgical site is the result of a microbial contamination of the surgical site itself. We know there's, microbial sources that can happen in reference to the androgenous, meaning that the bacteria from the patient's own skin, as well as there's androgenous, as well as meaning reference to the environment, healthcare providers, as well as surgical equipment can be a factor of this as well. But we know from clinical evidence data that the number one pathogen that causes all HAIs, including surgical site infections, are Staph aureus across the board from clinical data. We know that. Also, we know that the CDC put out from the vital signs saying that Staph kills, and that we have to do more not only in acute care settings, but also in reference to the community settings, to how we can prevent these infections that are caused by the number one pathogen that causes surgical site infections and others as well. So if we look at other risk factors overall in reference to for surgical site infections, here's a good example in reference to looking at the risk of the stratification for SSIs in colon cancer. This was a retrospective study that included over 1,400 patients from Massachusetts General Hospital from a 10-year period. And what they found was that stratified, risk factors are the following: from those patients who are smoked versus those who do not, patients who abuse alcohol, patients who have type 2 diabetes, obese patients, as well as the risk factor of if the surgery duration was longer than 140 minutes. But also, if you combine those risk factors together, unfortunately, you have a higher risk factor as well, meaning that the patient with one or fewer risk factors, the risk factor rate would be 2.3. However, if the patient had 2 or more, it would increase twofold to 5.2%. If the patient had 3 risk factors, the risk factor for surgical site infection would be 7.8. And lastly, if the patient had 4 or more risk factors, it would increase greater than 13.5%, unfortunately. Now, this is a nice fish diagram from Dr. Chuck Evanston. And so it gives you a very high level overview of all the factors that can come into play when you have an increased risk of surgical site infections, not only for preoperative factors, but also it goes into perioperative as well as the organization management factors from the surgeon, the environment, and the patient as well. For my talk today, I want to focus primarily on the preoperative factors in reference to the lack of body decolonization for patients who do not prep their skin appropriately. And also we know that if patients have several or certain type of infection caused by Staph aureus, like MRSA or MSSA, with nasal decolonization, that's a key factor as well that can cause an infection for these patients. So if we look at the surgical site prevention strategies, they are the following. Clinical evidence have shown that preventing SSIs is the primary goal for all patients undergoing operation as well as invasive procedures. You have decolonization, strict aseptic technique in all phases of patient care, maintaining a normal temperature for the patients, also control of blood glucose level, and patient education is key as well. But we also know from the clinical evidence, from not only from what the Centers for Disease Control and Prevention, the CDC, and the World Health Organization, known as WHO, this is a nice review of the guidelines that shows that if you are doing a reduction of infections, both of the national and public health departments and government agencies states that a standardized shower 2 days before surgery, as well as nasal decolonization, is key to preventing these infections. So both guidelines stress that in both prevention areas. So for decolonization strategies, they are the use of a topical antiseptic or antibiotic to reduce the body surface bacteria to prevent carriage or infection. We know that from clinical evidence and from daily use that we commonly use chlorhexidine gluconate for the skin and for wound bathing, but also mupirocin, which is an antibiotic, and iodophor, also known as povidone, which is an antiseptic for the nose. We know you can use these antiseptics as well as the antibiotic for these vulnerable, high-risk populations of patients, particularly those who are going to the ICU settings and those who are having surgery. We know they can also be used against multi-drug-resistant organisms, as well as CHG and iodophor have been used in healthcare for over 60 years and have a good, strong safety record to prevent these infections as well. So if you look at decolonization prevention, what happens, in these unfortunate, events over time? And this is a nice presentation that was done back in 2015 with Dr. Susan Wong in a roundtable presentation she gave at the CDC. And here's my nice friend on the corner here to the right of your screen of a patient who is colonized with certain pathogens and just shedding in the environment. But we know that patients shed these pathogens, for example, Staph, aureus, or MRSA in the environment. Then the environment becomes contaminated, unfortunately. The contamination persists because of failure to clean or to disinfect the area. The staff acquires it because they fail to remove it from not having good, proper hand hygiene. The patient transfers to one patient to another, and there's the risk of an infection that can happen if you do not have proper decolonization strategies in place. We know that if you do decolonize, you can prevent shedding, but even more so, you will have a broader solution for all MDROs that are carriers as well as causing infections. And if you look to know, what are the MDROs that we're dealing with currently right now, these are a nice list of the deadliest pathogens that we have, unfortunately. And these are all positive for gram-positive, gram-negative, as well as some fungus that we have here that we're dealing with MDROs. But two different strategies that we use in healthcare when we're trying to prevent infections in reference to decolonization. The first one would be a targeted decolonization, meaning that the patient is screened on admission for Staph aureus or MRSA carriers, in the nasal cavity. If the patients are positive for that, the patients undergo decolonization remedy from the skin as well as the nares. However, for universal decolonization, we're more focused primarily on all patients who are subject to skin and nasal decolonization, but it's not specifically towards certain pathogens. So these are all pathogens that we're trying to reduce and to prevent infections from. And also we know here recently, back in March, the CDC put out nice guidelines in reference to saying that if you want to implement these interventions to reduce not only device but procedure-related hospital-acquired infections, there's a nice section here on this webpage in reference to the surgical site prevention. It actually states in reference to using mupirocin as well as iodophor or povidone with chlorhexidine gluconate washes or wipes in reference to preventing these surgical site infections, which is key. But not only does the CDC recommend it, there are other guidelines as well that say that you should have skin bathing prior to surgery to prevent these infections. They are SHEA, ARRN, APIC, as well as IDSA. They all say that chlorhexidine is a frequent recommended antiseptic, but is well known to use to prevent these infections caused by the pathogens on patients' skin. Not only are we thinking about in reference to these pathogens on patients' skin, we know from clinical evidence that there are patients who are just generally colonized with certain pathogens on their skin, primarily with Staph aureus. And if you see on the right-hand side of the corner, those are those patients who are Staph aureus carriers. And as you can see, the nose has 100%, they will be colonized with that, versus any other part of the body is not as high as those in the nares. And so you wonder, why do we want to decolonize, patients in the nose? It's because approximately 30% of the population is colonized with Staph aureus in the nose. We also know that majority, 80% of all Staph aureus infections are caused by patients' own skin flora. We also know that nasal carriages of Staph aureus is a significant risk factor of developing a surgical site infection, with Staph aureus in patients who are orthopedic surgery. And we also know that in orthopedic surgery patients, the risk of a surgical site infection caused by Staph aureus in the nares is 5.8 times higher than those patients who are non-nasal carriages. So we have to do more in the nose to prevent these cross-contaminations and causing infections, not only in the skin, but also in the nose. There's also professional guidelines for nasal decolonization that also stress and say that we should decolonize surgical patients with an anti-staphylococcal agent in a preoperative setting for high-risk procedures, including those for orthopedics as well as cardiothoracic procedures. Those are also supported by APIC, SHEA, IDSA, as well as ARN that stress to say that we can and we should use these, not only the agents for mupirocin, but also povidone iodine to stress to prevent those infections are key. But we know from traditional approach from decolonization, for many years we have used mupirocin, which is an ointment, has been traditionally used. That has been the gold standard for many years. However, studies have shown that for nasal decolonization with mupirocin, as part of the preoperative and inpatient protocol, can reduce the risk of infections. We know now, unfortunately, that there's a challenge that has arrived, that when you use mupirocin twice a day for 5 days straight, patient compliance can vary, unfortunately. But also, there's evidence that's shown that the mupirocin has a high resistance rate, unfortunately, that we've been using, unfortunately, as well. So we know now from back in 2015 where the CDC and the White House put out the call to action in reference to we need to educate and train more about antibiotic stewardship by using these antibiotics inappropriately as well as unnecessary in the acute care settings. We also know not only that mupirocin is a problem not only in America, but this is a global problem in reference to mupirocin resistance. As you can see on the left-hand side of the screen, several countries, not only cities, but several countries like New Zealand, Western Australia, Brazil, they all have seen a high level of resistance of mupirocin over time. But if you see here in the U.S., there was a study that was done with 29 ICUs and 13 U.S. hospitals, just over, I would say, an 18-month time period. The high level of resistance increased from 10% to 17% for the mupirocin being used for those patients, unfortunately. So we have to do something more to prevent not only the MRSA outbreaks, but also a different approach for an effective use when we're trying to have an alternative for nasal decolonization. We know that povidone iodine has been widely used, and there is a non-irritation for using that for patients. We know also that it's very active against gram-positive and gram-negative bacteria. also to date that there is no evidence of bacterial resistance when you use this. Very different from using mupirocin versus using povidone before surgery. The healthcare provider can apply this 1 hour prior to surgery. That makes it more of a higher compliance, but also it's easy to use as well, with less patients for reactions, as well as none that with some irritation as well for patients. So now I want to get into the actual clinical evidence that is related to the use for effective antiseptic agents to reduce surgical site infections that we have. The first one, we could look at the home application for surgical site prevention using CHG. This was a study that was done, looked at patients who used the 2% CHG impregnated cloth before surgery for shoulder surgery to show that using the CHG versus using soap and water. And as you can see from the actual table below, that the overall rate for cultures for patients was much lower for those who bathed with the CHG cloth versus those who used the soap and water bathe for surgical site prevention. Here's another study that was done by Dr. Chuck Edmiston to look at comparison of a clinical trial of looking at clinical efficacy for cleaning with CHG. This study was used to compare not only the 2% impregnated cloth and as well as 4% CHG soap by using externalization for time periods for those patients before they had surgery. And what they found was for patients who showered twice with 4% CHG, the liquid, or with the 2% CHG cloth, showed a mean MIC ratio ranging from 25.3% to 350 times the concentration required to kill a Staph aureus, including not only MRSA but also MRSA as well. Now, for several clinical evidence, we have seen for many years that they have recommended for patients to shower 2 nights before surgery. However, this was a study that was presented at SHEA this year from Duke University. And what they asked for patients to do is from this multi-center, non-randomized prospective cohort study for patients who are undergoing not only hip and knee replacement, but also for those who are having spinal surgery as well in 2 large-scale academic centers. Patients were given 1 or 2 instructions here in this study. They were using, in group 1, CHG soap was given for 5 days prior to surgery, and also the day in the morning of the application. In group 2, they used CHG scrub just the night before and the morning of, which would be a total of 2 applications of CHG. And what we have found here on the actual screen overall, in the blue bar, that would be considered in reference to the high concentration of CHG from the 2-day scrub versus the 6-day scrub was higher in reference to the 97% overall. And what they found was that preoperative 6-day CHG scrub application led to a higher skin preoperative CHG concentration versus the 2-day scrub roach approach. The higher proportion of patients who met the CHG concentration threshold for gram-positive bacteria as well as Klebsiella pneumoniae, carbaminopase producers with the 6-day application than the 2-day scrub brush application in this cohort for patients. So even though we know from data, they always ask patients to do 2 nights before, this is an example of you can actually increase it not only to 2 days, but also to 6 days in the morning of to prevent these infections as well. This is another study that was done looking at the efficacy for the advanced for preoperative CHG preparing protocol. And for these patients here, they were actually comparing those who bathed at home before surgery to prep their skin versus those who only got the preparation in hospital. And as you can see overall, there was a statistical significant lower level of infection for those patients who used the CHG at home, which was 0.5% of infections, versus those patients who only cleansed the skin in the hospital, which was close to 2% for those infections. However, in healthcare systems, we're not only trying to prevent infections, but also we want to implement a protocol that could be cost effectiveness. And we also see in this study that using CHG actually had a network saving of around $2.1 million for annual expectation for over $3.1 billion if they were to use this implement completely. So it's not only effectiveness to reduce infections, but it was also cost effective overall as well. But we know from big data from this facility that was done a huge study over 20 hospitals in 9 states. This was a huge bundle approach to use to prevent infections overall for patients who were going in for cardiac, hip, as well as knee surgeries. And what they did in this study here for patients, they had patients who was preoperatively nerves in the nose that was screened for those who were positive in the nose for MRSA, as well as MSSA. Also, patients were decolonized with not only mupirocin, but also used CHG bathing for the skin, and they also received a prophylactic antibiotic as well as a bundle approach. And what we saw here in this study that was done back in 2015, that after the 3-month phase-in period that was done in 2012 on your screen here, that the bundle adherence of 83% for all of those patients who were using this bundle approach intervention to prevent infections. Overall, there was only 101 infections that occurred after 28,000 operations during a pre-intervention phase. However, post-intervention phase, only 29 occurred out of 14,300 operations. So we know here that the bundle approach works when you're screening as well as decolonizing and giving prophylactic for patients for MRSA for surgery. Here's another example here in reference to using povidone iodine as an effective to reducing the risk of surgical site infections as well as lowering hospital costs. This was a very significant study that showed that they had fewer Staph aureus deep surgical site infections that developed in patients who were decolonized with povidone iodine, which was about 1.8%, compared to patients who was decolonized with mupirocin, which was 8.9%. So here in this study that was done back in 2014, that nasal povidone iodine may be considered as an alternative to mupirocin as part of the bundle intervention. Also, we know from universal decolonization, when you're using povidone iodine compared to just targeting for patients, meaning you're screening and treatment, as a result, there was a dramatic lower hospital cost, meaning that the mean cost for a nasal swab was around $27, significantly different when you look at the mean cost for MRSA screening, which is over $120. So if you don't screen patients on admission before and just decolonize them, there is also a net savings as well as a benefit to prevent infections too. So we know that, from a regional approach, that we have patients coming all over from the nursing homes, LTAC facilities, and they're bouncing around from state to state, so it can vary at times. But we know that there's certain, even though there's the same need for infection control, we do know they are not the same overall. However, this was a study that was done by Dr. Susan Wong that was published this year that showed that there are decolonizing patients after post-discharge, for those patients who are among the MRSA carriers. And what they did here was they conducted a multi-center randomized control trial in over 30 different facilities where they compared in one arm just to educate patients on what they should do to prevent infections versus another arm where they actually educated them, but also included a decolonization bundle where they used chlorhexidine mouthwash as well as they used mupirocin as well as CHG bathing for a time for 6 months, and they followed these patients over a 1-year time period. Overall, what they found was from post-discharge, MRSA decolonization led to a 30% lower risk for MRSA infections than just education alone. So there's a benefit if you're trying to continue to decolonize patients not only before surgery, during their stay in the hospital, but also post-discharge as well. So for the past several I don't know how long, several slides, I've been focusing on primarily on the skin as well as the nasal. However, when you think about the use of long-term CHG, some may have some concerns with that. What I can tell you is that CHG resistance is always a possibility. However, with widespread use, CHG resistance has not been reported. Also, we know that CHG use should be limited to indications in which the benefits is well documented in how you're going to use CHG. Also, there's a question in reference to how does CHG affect the skin microbiome? And so we know from clinical studies that show when you are comparing CHG daily application to those who are being bathed with diluted bleach in the water, that topical decolonization does not eradicate the skin microbiota, meaning the good bacteria from patient's skin. And lastly, we know that there are certain ethnicities that may play a role in adverse effects, meaning those patients who are Asian or Japanese patients may have a more susceptibility to develop an IgE immune response to chlorhexidine than those who are Caucasian frequently. We also have seen in the past too from those same population of patients that when they use a CHG-coated catheter, they have a more reported of having an adverse effects versus those who are not. So speaking about just CHG overall, not only for decolonization for the nose and for the skin, I think the mouth decolonization is also extremely, extremely important, and it also plays a critical role in preventing infections. We know that if we don't have, antibiotics, antimicrobial stewardship programs in place, as well as good agents that are involved, like CHG, that there's a cost involved in reference to ventilator-associated pneumonia as well as hospital-acquired pneumonia. If you don't have that, the burden of those infections can range from $19,000 to $44,000 per infection for those patients, unfortunately. And if you look at big data from the state of Pennsylvania, they showed as well that the risk of having, for example, non-vented hospital-acquired pneumonia cases for over a 3-year time period, they had over 5,000 cases of that, which cost over $150 million to treat that. So we have to do more when we're trying to prevent the non-vented hospital-acquired infections for patients as well for VAP. But we know that from data that not only that you find in a community setting as well as in the hospital, that Staph aureus and MRSA can be all over the patient's body for anatomic sites as well. This is a study that was done back in 2014 here in the Chicago region, where we looked at atomic sites for community-acquired MRSA. And one of the areas that we found a high level of it was in the patient's throat as well, which is interesting, which shows, it goes back to what the CDC focused on from the vital signs, and that we should be doing more, not only in acute care settings, but also in the community base, because there are patients coming in the healthcare systems. And we know that a picture is worth 1,000 words when you can see over time a bacteria that can grow in the patient's mouth for those who are not decolonized or using anything to clean the mouth appropriately. We know that an unclean mouth can have about 100 million to 1 billion bacteria on each teeth, meaning the plaque for it. And also we know that oral bacteria can replicate 5 times within a 24-hour time period. So we have to do more to prevent these infections. Also, we know that 80% of all infections are caused by the formation of the biofilm. So we not only need to have the rinse of using the antiseptic, but also the mechanism of using a brush, which is a good picture here on the left-hand side of the screen, and the one in the middle actually shows a single brush from a patient with bacteria from the mouth from cleaning their teeth. So we have to do more trying to prevent not only the surgical site infections, but also for pneumonia as well. And there's a JAMA study that was published that showed when you have a bundle approach, it can reduce infections, but also when you have a universal decolonization where you're using povidone iodine with not only pre-surgical CHG bathing, and when you use an oral rinse like CHG, it can result in a 70% reduction in infections compared to no decolonization strategy at all completely. We also know from a clinical evidence study here that was done looking at 2 big clinical studies for over 2,000 patients as a review of looking at patients who use CHG to decolonize their mouth before ongoing, elective surgery. And what they found was there was a huge reduction, not only for using CHG, but when you compare those patients who had post-operative pneumonia versus those who did not decolonize, we know that the range from using CHG decreased the infection rate to 5.3% to those who did not use CHG for post-operative pneumonia. It increased double by 10.4%. So here's a good example here where patients are undergoing not only just surgery, but elective thoracic surgery or cardiovascular surgery. If you decolonize their mouth, including as well, you can also prevent postoperative pneumonia. This is another study that was done in the annual thoracic surgery this year that was published, and it looked at patients who are undergoing pulmonary resection were postoperatively enrolled in a single-arm intervention study with a time-matched control, meaning that one arm of patients, they actually brushed their teeth with CHG 3 times daily for 5 days before they had the operation and 5 days or until the time of discharge afterwards, and compared to the control. The control unit here for patients actually just has standard of care and meaning of more of an education of oral hygiene, versus those who use CHG over time before surgery had a lower rate of infection of 1.6% versus those who did not use the CHG before surgery was 4.9%. We also saw in this clinical study in reference to the cost estimate of one postoperative pneumonia would be around close to $500. So whereas if you would think for the prolonged hospital stay for pneumonia would range from $5,000 to $17,000 per patient. So if we can prevent these infections by just decolonizing a patient in the oral care, but also for the nose and on skin, we can prevent infections as well as have it cost effectiveness. Lastly, here, this is a study in reference to how the effect of oral care hygiene as well as using CHG or rinse to prevent VAP for patients after they had cardiovascular surgery. So what this study showed was this was a study for ongoing patients for the heart surgery that were enrolled in the protocol. And they had 2 groups of patients, and in each group there was 150 patients. And one group, the patient actually used or CHG brushing and also for rinse for one group, for group 1. In group 2, there was no oral decolonization. As you can see in the highlighted red box there, that overall they had a lower number of infections from not only for VAP, but also for surgical site infections, deep and sternal infections as well, was lower than those patients in group 2. But if you go even lower, even more so in reference to those patients per the pathogen that you can look at here in the red box as well, we know that Klebsiella pneumonia, Pseudomonas, and Staph aureus, and other pathogens here, they had the least amount of pathogens that was found to cause an infection versus those patients who did not use the oral decolonization, actually doubled for those populations of patients in group 2. So just doing a simple thing as decolonizing not only in the nose and the skin, but the oral care as well has a huge factor to not only prevent surgical site infections, but also for pneumonia as well for those patients too. So we know that the core universal infection control strategies to prevent all infections, not only pathogen specific, are very important. They are optimal hand hygiene, universal cleaning and disinfecting, vaccinations, as well as antibiotic stewardship with decolonization. However, when you're trying to prevent surgical site infections with a decolonization bundle, the patient plays a critical role in that process because we want to make sure that they are adhering to the education process, meaning that you want to make sure that the success of implementing a pre-admission showering protocol is included. You want to have a good partnership or active partnership with your patient, but also making sure the patient understands the protocol and why it's important to reduce these infections, because there are certain 4 things that we have to have in place to make sure the patient's compliance as well as education is key. They have to know the risk factors of the surgical site infections. So that should be provided to each individual before they have surgery. Also, the instructions to make sure they understand how to use the protocol when they're at home for bathing for the CHG. Also, it's extremely important for the patient to have access to the product itself. Patients have so much things going on right before they have surgery. They're in real world situations. They have family, and it's hard for them to go to a pharmacy to pick up things, but it'll make it very easy and simple if the healthcare provider provides them with the product itself. Also, I know probably in my speech here today, several individuals may have checked their phone for something, for email or text, but we do know from clinical studies showing that if patients have reminder systems, it's key. That can be either via email, text on the phone, a phone call. All of these are very important that we should have to make sure patients have a high compliance rate, to make sure they use things appropriately to prepare for surgery. And there was a study that was done back in 2014 that demonstrated that electronic reminders are effective in achieving patients' compliance for pre-admission shower procedures. As a result, they found that electronic alerts that were sent via text, emails, as well as voicemails was very appropriate and helped for patients. About 80% of the patients prefer to see or to receive a text message, which is not, we can all, agree to that, in that same for those patients. But also we know that for those who did not receive those reminders had a 66 reduction in the mean concentration of CHG on their skin. So it wasn't as high for that. So for this study that was done for those who had the reminder, again, as I mentioned earlier, some of the data shows that you can bathe 2 nights before, 3 nights before, sometimes 5 nights before. They're all correct. There's no wrong way of doing it, I would say. But as long as your patient is getting the bath before surgery, that's key to have. In this clinical study here, they had a mean concentration of using 4% on their skin. As you can see in Group A1, they actually received the phone calls for pre-showering 2 nights before and the morning of. In Group B, they had the 3 showers before as well as the morning of for bathing. For those who actually had a higher concentration of CHG on the skin was in Group 1, they actually received the phone call, the electronic reminders to bathe appropriately. The exact same for those patients who had the 3-day pre-admission showers as well. They had a higher mean of CHG concentration on the skin to prevent those infections that are caused by these bad MDROs that we have, as well as for MRSA and for Staph aureus. So for my take-home message for you, I will say the following is: surgical site infections are costly and have significant impact on both the patients and healthcare facilities. Implementation of a decolonization bundle is essential, as well as demonstrated to reduce infections, not only for Staph aureus, for MRSA or MRSA, but also for those gram-positive bacteria and gram-negative bugs that we saw from the Duke University study as well, from those KPC. They also reduced the number of infections, caused by these MDROs. Also, we know that antibiotic resistance is a global issue. It's a public health concern. We need to do more to make sure we are giving our antibiotics appropriately, but we also know that antiseptics are an alternative, and they are very effective to preventing infections that we can use not only in the surgical site prevention area. And lastly, preventing the development of surgical site infections is critical for improving patient safety and also promoting optimal outcomes for patient education. So it's always key. So I'd like to thank everyone for listening, and I truly appreciate it, and I'm open now for questions.
That's great. Thank you so much, Rosie. We have got a few questions. The first one is, have you heard of these new recommendations by the CDC that came out in March for prevention of MRSA?
Yes, I think I do know what you're referring to. It was in reference to the strategies to prevent the hospital onset of Staph aureus bloodstream infections in acute care settings. On this site, they also focus on the implementation interventions to not only to reduce devices like CLABSIs, hemodialysis, and bloodstream infections, but also they focused on procedures related hospital associated infections like surgical site infections and VAPS as well. And they had strong information from public or published data to show why you should decolonize and have decolonization strategies in place for evidence-based to reduce these infections. So it wasn't only focused on not only for on hospital on-site infections for CLABSIs, but they also focused on surgical site infections as well.
Okay, that's great. So if you're not pre-op screening patients for MRSA, Staph, or MSA, is it necessary to have those results to determine whether or not you will decolonize the patient?
Oh, that's a good question. I know there are several states that have mandated hospital screening, for MRSA. I know my own state here in Illinois has done that, as well as California, and about 5 others, I do believe. But if your facility is moving away from screening by PCR, in the clinical study that I showed previously in that 20 hospitals over 9 states, in that clinical study, which is big data, showed that if you did not have, any screening results or didn't know if the patient was positive for not only Staph aureus or MRSA or MSSA, you can still decolonize patients by using the antiseptic products as well as the CHG and povidone to decolonize those patients. We also know that we want to make sure that we look for certain patients who have certain high risk for MRSA, and you look at those individuals, coming from settings of high endemic rates of MRSA, patients who are living in extended care facility or nursing homes, those who are on dialysis, prior history of MRSA colonization and infection, if patients who are IV drug users, if a patient is transferred from an acute care setting within longer than 48 hours, also if you have a patient who requiring chronic wound care, and lastly, if a patient's undergoing a cardiothoracic surgery as well, is key.
Great. Do you see any uptake in the application of decolonization strategies for post-discharge patients?
I would say yes, because we know that decolonization has successfully prevented disease during temporary high-risk circumstances, meaning that patients who have skin or recurrent skin infections or ICU care, those who are having knee or hip replacement, as well as cardiac surgery. And using like that 5-day decolonization strategy to reduce those short-lived MRSA clearance is great. However, we know from the Project Clear that I showed in reference to patients who are decolonizing post discharge, there are several months that they actually can be discharged over time and be decolonized, by using that regimen that was in Project Clear that showed that you can reduce not only readmissions, but also the MRSA infections for those patients who are discharged by doing that.
Okay, that's great. Another question is, attendee says, I am from an ortho outpatient surgery center. What would be some good goals for antibiotic stewardship, even though we don't prescribe antibiotics post-op? We do use the typical day of pre-surgical antibiotic as a patient is going to the OR.
I would say for antibiotic stewardship, it's very important when you have that protocol, that process in place. It's normally done by an infectious disease doctor who is making sure that the patient gets the appropriate antibiotics, the dosage, and duration over time for a certain pathogen. If you don't have that in place, I think it's good to have evidence-based data to support the use of antiseptics like povidone and CHG for those patients, and making sure they're compliant with that before surgery, as well as aseptic techniques while the patient is there, and also post-admission as well. So having that is key to it.
Okay, that's great. That was very helpful, I'm sure. Should CHG be rinsed after applying on a patient?
So that is a tricky question, I would say, because there are several products that you can use for CHG. So for that individual who asked that question, I would prefer to, if they would send me an email and I can explain in more detail, because CHG is used primarily not only for surgical site prevention, but also used in the ICU setting. And I want to make sure I answer it appropriately, but I also make sure I am speaking to what they're asking appropriately, because there's different types of CHG products. And so I want to make sure I'm answering correctly if possible.
Okay, that's great. So that is just a reminder to attendees, you can email Rosie directly with questions, especially if we don't get time to get through all the questions, and she will answer at her own convenience. Anyway, here is another one, Rosie. Is there a recommended cadence for pre-op oral rinse to go along with our current bundle?
Yes. So you can use a CHG rinse as well as a toothbrush right before a patient has surgery. So that is also in the thoracic surgical guidelines, as well as the American Dental Association as well, for trying to prevent patients with pneumonia. So there are certain guidelines as well as procedures in place to use and recommend that you do decolonize the mouth as well as the teeth by brushing before a patient has surgery. The same process you would do if you're using the povidone iodine for the nose. The healthcare provider would provide not only the povidone iodine in the nose, but also the CHG, the rinse, as well as a toothbrush for patients.
Okay, that's great. I've got a question about, can you explain any difference, or what the difference is between 5% povidone iodine swabs and 10% povidone iodine swabs?
Well, for the 5% povidone iodine swabs, they are, from my understanding, they are liquid povidone iodine, versus those that are 10% povidone iodine, they are gel. So it all depends. It's more effect of the consistency of the povidone iodine. One is liquid and the other two is gel.
Okay, that's great. Another question here is, with a known history of MRSA, should you use both, I hope I'm pronouncing this right, mupirocin and P07?
I think they're asking if a patient does not have a history of MRSA or MSSA, do you need to use mupirocin to decolonize them? If that's the question, I would say with the range of patients who are using mupirocin, and also with the increase of resistance to it, if the patient cannot take povidone iodine, I would recommend, yes, the next step would be to use mupirocin, which is the antibiotic, if a patient could not take or had any reactions to using povidone iodine.
Okay, I think it looks like we've got no more questions, Rosie, and we're coming up to our limit. So thank you once again for a great and informative webinar, and thank you again to our sponsors, Medline. Just another quick reminder. Oh, sorry. So just another quick reminder that we have now automated the post-webinar survey and certificate process. The survey link will be included in the follow-up email, which you'll receive in about an hour's time. Once you've completed the survey, you'll be able to download your certificate immediately. One lucky attendee will win an Amazon gift card for completing the survey. Of course, if you have any questions, please don't hesitate to contact us at webinar@mdpublishing.com. For more information on our upcoming OR Today webinars, please visit our website, ortoday.com/webinars. So thank you once again for joining us today. Enjoy the rest of your day, and we hope to see you next time.